It is a huge honor for me to be podcast interviewing Dr. Pavandeep Khaira, which is only known by Pav on Dental Town. He's got 4,000 posts on Dental Town since 2006. He's one of my idols and role models and heroes. And thanks for doing this podcast with me, Pav.
Not anything for you, Howie. I was going to say the same about you, about following all your posts, and you're a role model for me as well. So we're all in this together.
Well, I'm sure I'm your role model just when it comes to diet. Diet, right? I'll teach you how to eat when I'm in London. Am I going to see you next week when I'm in London? Or
send me a message. I'll see what my diary's like.
Okay.
And I'd love to meet up with you. Absolutely, yeah.
I love the different languages around the world. Check your diary. In Arizona we'd say calendar, but
Yeah.
I love that joke that England and the United States are a common people separated by a common language.
Yes,
Or something like that.
Yeah.
So Pav graduated from Guy's Hospital in London in 2002.
That's
Found
correct.
a passion for learning new things and pushing his clinical skill set. Having undertaken a lot of CE in restorative and aesthetics, he started to get bored and decided to start learning about implants. This was actually really worked well for him, and with implants, he needs to consider everything. He's currently undertaking a Dip.Implant.Dent and MClinDent in implantology in London, and have completed the Dental XP externship with Stony Brook University in New York City. His focus is on dental implants, and he plans to continue his education to be able to perform more surgery that he's comfortable with.
Yeah, that's about right.
So how are you doing?
I'm really good. It's I sent Ryan a message earlier on today. I said, look, exactly what time are we starting? And he said 8 o'clock. So I got back a little bit early. I've just done a 45-minute cardio workout. That's why my face is looking all red and flushed at the moment. So I've done my workout. I'm full of energy. I feel fantastic, and I'm speaking to yourself as well. So
it's 12 noon. It's my lunch hour right now. It's 12 noon here on a Wednesday. What is it there? Wednesday night at
8 o'clock in the evening. Yeah,
8 p.m. And I'm also really excited. Flying to London, they actually have a non-stop flight. Usually for 20 years, I had to fly a 5-hour flight to New York, having a layover, then a 6.5-hour flight to London. And this is a straight shot, 10-hour nonstop from Phoenix to London.
The world's getting smaller.
It is. Isn't that nice? So how did you get into implants? I mean, you just have a very interesting journey. You got big into implants. You decided not to own your own dental office. You would just go place implants in other people's office. Tell everybody what you're up to.
Well, I did actually own a practice for quite a few years, nearly 9 years it was. And it didn't really fit my personality style at all. I know some people take to it really well and they thrive on it. I considered myself more of a leader as opposed to a manager. And anytime any stressful situations came up, then it was, I really struggled to make the clear-cut business decisions. But when it came to the clinical dentistry, I always loved that. It got to the point where I'd had enough of owning my own practice. I got rid of it, and I started to work as an associate in a number of other practices. And this was about the time I was just starting to do more and more implants. And what ended up happening is I ended up doing more and more implants, and it's now gotten to the point where that's pretty much all that I do. So I don't do any general dentistry anymore. It's taken me several years to get to this point now. So it's a long journey. It doesn't happen overnight, but it's one that you got to keep with if you want to get to that end goal, really. So I've just been developing it over a number of years, and I had a few practices where they said, "Oh, we'll keep you busy." You go in, and they're not really busy, and and then you find the right practice, and they do keep you busy, and it works out for everybody's interest. So that was my journey to becoming an implant surgeon, basically.
Well, there's a lot of kids in dental school that listen to this. So what do you tell them? What aspect of owning a business you didn't like? Because I think a lot of people will, like a CAD/CAM machine. Just because I buy a piano doesn't mean I'm going to be Beethoven. I'm going to have to spend 10,000 hours on it. If you don't like lab work, why are you milling this out chairside and staining and glazing and et cetera, et cetera?
Yeah.
what specifically, and right now a lot of American kids come out of school and they've got options. You can go get a great
Yeah.
job in corporate. What did you not like about owning your own business?
Um, it was a lot of the regulation that came with it. And in the UK over the last few years, the regulation has just increased and increased. And it got to the point where it was, I mean, in our sterilization room where the autoclaves are kept, there's a certain flow that you have to have, and it got to the point where the airflow has to be in a certain direction as well. So you have to demonstrate that you've constructed everything and the airflows in a certain direction, and it's all tick boxing stuff. And I was never overly comfortable at that. I was comfortable with regards to what I was doing. I was hitting all the standards, but we've had what's called the CQC, the Care Quality Commission, come in, and they've introduced further regulation. And I understand the need for it, and I agree with it, but I just didn't like that aspect of it. And every single month it was just like, oh, Pav, you know what? It's £500 to have this service. It's £500 to have that service. It's another £300 because we need these testing. We need that. And every single month it was just one thing on top of another on top of another. And it just got too much. I enjoyed going in, helping my patients, but then after that, there was if there was any staffing issues, one of the girls would call in sick, and then if something happens to your chair breaks, and it's like now if a chair breaks, I called the practice owner and I say, chair's not working, I'm going home, I'll see you later. Whereas before, when you own a practice, it's like, oh God, just please don't let it be a new chair that I have to buy. So for me personally, working as an associate actually fits my personality style, because I go, I consult, I do the treatment, I come home, that's it, that's all that I have to do. I can focus on my patients 100%. And I know that some people like the managerial aspect of it, and but as I said, it just didn't fit my personality style. And this is what I say on the board sometimes, that I see a lot of very young dentists turning around and saying, oh, I'm going to buy a practice. I'm going to do it straight out of dental school. I just turn around and say, whoa. I said, look, if you want to do it, that's fine. Everybody's telling you to do it. I said, but speak to the people, because there's plenty of boards on there as well where people are turning around and saying, I've struggled with my practice for years. I've struggled with I'm struggling to get patients in. So there's two sides to every coin. And I fell in that category where I did struggle for a long time, and I didn't like the stress that came with it.
Oh, the list is a mile long of dentists who made the most money in their life as an associate. They were working for someone else, making 175, 225,000 a year, but their territorial instincts just kept saying, "Well, I have to own my own place." And then they doubled their work hours and cut their income 30, 40%, and were overworked. And so it's two separate skills: owning a business and doing dentistry. I'm always amazed at how many people come out of dental school, and when you talk about, well, do you like to pull wisdom teeth or place implants, they go, I don't like blood. And I'm always thinking, how the hell did you go into dental school? I mean, did you not know it was part of the human body? I mean, you listen to him and you think, shouldn't you have been like an engineer or an accountant or in finance? How do you say I want to go be a dentist and then say I don't like blood?
You know what it is? It's the prosthodontists who don't like blood, because as far as they're concerned, if the gingivae are healthy and if you've got correct retraction control in, you shouldn't actually see any blood at all. So they're the dentists who generally don't see any blood, because they refer out to the hygienist and periodontist, let them deal with that. By the time it comes back, there should be no bleeding.
Well, the two fastest growing segments, at least in the United States, I don't have the stats for your country, England, but is the pediatric dentistry at the one end of the spectrum, and then the other end, the geriatrics, is with implantology, because the baby boomers are retiring at like 10,000 people a day, and they don't want to have removable dentures, or they don't want to have dentures.
Absolutely.
So I assume, I would guess, probably 4 out of 5 people listening to this podcast have never placed a single implant.
Yeah.
So what? Talk them through your journey. How do you get from I just walked out of school to where Pav's sitting there right now?
Firstly, probably don't take as long a path as what I've taken. I graduated in 2002. I've been restoring implants probably since about 2006 or 7, but I didn't start placing till about 2012, 2011. So there was about a 9-year period where I didn't place. But what I did over that 9-year period is I did a lot of courses with Howard Chazalin and Frank Spear in the UK, Mike Wise, people like that. And so, you know, I had my restorative base, and I understood that before I actually moved on to the surgical aspects. And I think that's actually really important because, you know, back in the day, implants used to be, you know, put an implant wherever the bone is and figure it out afterwards. It's not like that at all anymore. There is no excuse for that type of implant placement anymore. But you need to understand the restoratives, and then as soon as you understand the restorative, then you can start to move on to the actual surgical aspect. And I think a really good place to start, and a lot of people say this, is reading Carl Nisch's book. You can spend tens of thousands, or you can spend hundreds of thousands on education, but you forget some of the basic stuff. A few £100, a few $100 for a textbook. And I guarantee you, if you read Carl's textbook and you understand it, he's not going to turn you into a world-class implantologist overnight, but it will give you the basic information so you can start to think in that direction, and you can start to see how to plan implants. And that is a really good place to start.
Well, you know, that just means you're street smart, because you can buy a textbook for a couple $100 or a couple £100. What is the pound of the US dollar, by the way?
I think a pound works out to about $1.30, $1.40, something like that.
Okay, 145. And but yeah, street smart people can go read a textbook for a couple $100, and
Yeah.
other people have to fly clear across the country, stay in a resort, and spend $5,000 for a weekend course.
Yeah.
And the person who stayed home and read the textbook actually probably learned more.
Yeah.
And it was amazing when I would go to Mish's course. You know, it seemed like every person that ever raised their hand and asked a question, I was just sitting there like, dude, that was in chapter 3. Dude,
Exactly.
that was in chapter 5. And you
Yeah.
and he just gave you a 3-second answer. You need to see the chapter, and
Yeah.
you know, yeah. So it is, and it's hard to even say to watch television for information. I mean, like, I don't care what documentary you're watching on the universe. I mean, it takes them 5 minutes to teach you one thing to write down on a Post-it note. Where if
Yeah.
you just got a book on that subject, you learn so much more. So what hands-on did you get? So Chaslin and Frank Spear were more restorative.
Yeah.
What did you do for the hands-on?
Well, when it came time is I did a little bit of research because in the UK, the General Dental Council says you need adequate training to place implants, but they won't really define what adequate training is. And a gentleman who's now my friend and my mentor I did a little bit of research, and I did a year-long program where I'd go down one day per month over a 12-month period. And so the first like 5 or 6 visits, it was all theoretical. And then we started doing where we'd go down and we'd vet the patients, and we'd have to do a presentation. This is the patient I want to treat. This is what my treatment plan is. And then we started doing it hands-on. And it gave me enough to start placing like the easy, straightforward implants. Now, the issue that I had is I didn't understand what easy and straightforward implants were. So even at that stage, I was probably doing cases that I shouldn't have done, that I'm comfortable doing now, but back at that time I was pushing the envelope a little bit too much. And what I did is at that point, because I was speaking to my mentor, I said, look, I really enjoy the implant aspects of it. I said, I want to do more. And his advice to me was, what you need to do is you need to figure out some way so that you can do volume of this. He said, if you're only doing 1 case a month or 1 case every 2 months, he said, you will not build up the confidence to be able to do this. He said, you need to start doing 1 case a week, 2 cases a week, 3 cases a week, and build it up like that. So what I did at the time is I did a significant discount on a fully restored implant compared to other practices in the area, and I marketed that. And because I was cheaper, I had a volume of patients come in, and that I remember there was 1 month I placed like 50 implants in a month, and that was when I just started.
Wow!
And it was just just enough to get the ball rolling for me. And what ended up happening is, you're doing your first one and you think, yeah, it's great, it's fine. You take the post-op periapical, it's off at an angle, so you've got to back it out and do it again. You think, why did that go wrong? And you figure out, oh, it went wrong at this stage. And then each one, you start to become more and more confident at it, and it becomes a little bit easier. And you have this failure, you figure out why that failed, and then you move, you start altering your technique accordingly. So it is a learning game, and this is why I don't think, because again, I read on the boards, oh, I'm just going to do a hands-on course. Well, if you don't have the theory but you do the hands-on, how do you know what you're doing? And the converse is true as well. If you have the theory but you don't know how to do the hands-on, you're still not going to be able to do it. You need a combination of the two. And then after probably about a couple of years or so, that's when I decided to re-enroll at the university, and that's where I'm doing my MClinDent now in implantology. So I'm halfway through my 3-year course now, and I've learned loads. I've learned loads.
Well, tell us everything you learned in 5 minutes.
In 5 minutes.
Well, go over the. My job is to try to answer the questions they're wondering. Are you agnostic to implant systems? Is titanium, or do you really like one system more than the others? I mean, there must be 175. Almost once a month, I discover a new implant system.
It's way more than 175. I think globally there's thousands of different implants that you can use, and there's a thread about this at the moment. And from everything that I understand, and please understand, it's my interpretation of what I know, is titanium's titanium. Your body doesn't know, as long as it's a certain type of titanium, as long as it's got a certain macro design, and as long as it's got a certain type of surface treatment, your body doesn't know one from the other. The biggest overriding factor by a long shot is the clinical skill of the operator. And it's understanding how to raise the flap and how to graft properly and how to keep the tension off the flap. My last assignment, it was to research grafting protocols and what works and what doesn't work. And I was, the task we were set was, based upon the evidence, come up with a decision tree for your practice. And I thought, this is going to be interesting. The bottom line is, Howard, everything works. Is block grafting works, cortical plate grafting works, large GBR cases work. They also all fail. Now, the key that I found, the underlying theme to everything, was flap tension by a long, long shot. If there's any type of tension on the flap, and I'll send you a copy of my assignment after we finish this, if there's any type of tension on the flap, the amount of blood vessel ingrowth, actual angiogenesis you get, reduces very significantly. So as long as you can keep the tension off the flap with tenting screws or muscle release, everything along those lines, that's when you'll have success. And if you do that, you use whatever technique you feel comfortable with, because it'll work.
So you're saying it's all in golf, it's all in the clubs. If I just buy the best clubs, I'll be a great golfer.
No. So
what you're saying, it's not the golf club, it's not the implant, it's the person using the implant system and the golf clubs.
Yeah. And it's like when people turn around and say primary stability. What's my primary stability supposed to be? Well, it depends on the patient, and it depends on the implant system that you're using. Because what's high for one implant is going to be low for another. So you need to understand what you're biologically trying to achieve.
I want you to back up just a little bit. Pav, one of the hard realities about implants is that all the patients in our practice that need implants lost their teeth because they weren't really ideal patients. They were smoking and drinking and drugging, and they were doing everything wrong. So if I read the ideal patient for implants, I wouldn't be doing any implants. I mean, I don't need implants. My son Ryan doesn't need implants. But the person who's did a lot of stuff wrong, they got gum disease or smokers. Will you talk about the health history? I mean, about in treatment planning a health history. I mean, are you are you placing them in medically compromised or, diabetics, obese, smokers, alcoholics?
I take all the risk factors into consideration, and then I also take into consideration the patient's attitude as well. And this is one of the soft skills that takes time to learn. That when patients are turning around and saying to you, "Oh yes, I will do this to look after the implants. I will do that to look after the implants," and I've now learned to spot those who bullshit me. And if they end up lying, I just turn around and say, "Look, I don't think I'm the right person to do this for you," and I let them walk. Is if somebody is periodontally compromised and they really want to have treatment done, is I turn around and say to them, "Okay, first we're going to do your gum disease treatment. Then you're going to come back to see the hygienist every 2 months, and we're not placing implants for at least 6 to 9 months. Demonstrate to me over 6 to 9 months, you're going to keep to your word, then we'll do it."
And then
it's the same.
And then they say, doesn't the alcohol in the beer kill the germs?
Yeah.
And then another issue that we see a lot is cleansability. So the person who had no home care, lost all these teeth, now has all these implants and fixed bridges that they never had the behavior of cleaning before they had implants. So who's surprised they're filthy now and have peri-implantitis? Do you think dentists are putting too much fixed on implants and should be doing more removable because it's so much easier for a patient to go to the kitchen sink and pop out their teeth and rinse them and brush them in their hand?
Yes, particularly for the older patients who may have arthritis, who don't have the manual dexterity to do that, is you can do something on locators, they can pop it out and it's much easier for them to clean. I also think that the actual soft tissue it's not augmented as often as what it needs to be. Thomas Linkevicius has done a number of studies where he's shown that if your soft tissue thickness is under 2 millimeters, no laser locking, no platform switching, no thread design, nothing's going to preserve the bone. If your soft tissue thickness is above 2 millimeters, you get much more stable bone long term. So what's happening is, particularly in the lower, in the lowers where people have got their premolars and molars missing, is if they've been missing 6 months, you come to it and the soft tissue is very thin in that area. And I say to those patients, first what we need to do is we need to do a gum graft, wait for that to heal, then we'll come back in about 3-4 months and we'll put the implant in. And that's part of the integrated treatment plan. You can't just put the implant in because the gum tissue is too thin. The whole argument of do you need keratinized tissue, do you not need keratinized tissue, that's no longer a question anymore. So to answer your question, yes, it should be patient specific, taking on board A, what the patient wants, and B, is if you think they're going to struggle with it, make them something removable that they can clean, but also look at the more difficult things. And let's face it, is putting in implants is easier than doing a soft tissue graft, but it's the soft tissue graft that is just as important as anything else long term.
Yeah, and it's also a side effect of so much marketing when people are saying, one appointment, implants, walk out in 1 day with your teeth, or same day crowns. Someone comes in and wants a same day crown and they need 4 quadrants root planing curettage and they need 6 other fillings and the crown is the least of their worries. So what implant system did you go with?
I'm currently using Megagen.
Megagen. And it's okay, so it's past June 1st. Wasn't there option June 1st from was it Noble Biocare? Didn't Noble Biocare offer to buy that company and they had to decide by June 1?
I can't remember. I've not heard that. I know Straumann invested in them.
Straumann, yeah. I'm sorry.
A while ago as well.
I'm just mixing them all up.
Yeah.
So Straumann, so their wasn't their deadline they invested in it, but anyway. So is it part of Straumann now? It's past June 1st?
I don't think it's part of Straumann, but I know Straumann, they put a lot of money into Megagen, and this was about a year or 2 ago. And it's a relatively smaller company in the UK compared to some of the other implant systems out there. But a lot of the top implant surgeons in the UK are starting to use it. And I don't know what to tell you is, I can lock those implants into an immediate extraction socket when there's 2 millimeters of apical bone, and still get 30, 35 Newton centimeters, and they just integrate beautifully. And from a restorative aspect, I find them really easy to use. So
I think what the Koreans did better than the Europeans is they went from design. They had dental offices that were 10 stories tall, and
yeah,
it could go from the design to manufactured and place 100 like
yeah,
literally in 10 days.
yes,
And where the Europeans, they would think about it, they would design it, they go to universities, they'd issue studies. So
yeah,
the time between the modifications was very
yes,
long.
yeah,
Whereas Megagen, they could sink 1,000 of a new design and
yeah,
then know in 6 months what they have and then keep modifying. So
absolutely, yeah.
they were really modifying fast. But yeah, that's extremely fast growing implant system. So you like Megagen?
I do really like it, yeah,
And it's
yeah.
not really high cost or low cost. It's kind of in the middle, isn't it?
It's kind of in the middle, yeah. Yeah, it's in the UK at least. If you bulk buy them, they do you discount packages as well. But it's not the cheapest by any stretch, and it's not the most expensive by any stretch. But it is the system I've had the least problems with by a long shot.
So what's your bread and butter? Is it mostly single tooth replacement or is it overdentures or what are you mostly placing?
Mostly single teeth.
Mostly single teeth?
Mostly single teeth. And my favourites are upper premolars, either immediates or where they've been taken out about 3 months ago, right in the corner of your smile, and it's they're my favourite because they're so fast to do. They are is cosmetically they're nice, but it's not as important as your central right at the front. And I like what's the best way to explain this? I like the complex work because it pushes my skill set. But from a business point of view, per hour, you can generate more doing single implants. Because when you're doing full mouths, it takes a lot longer to do. You're going to run into more problems. You're going to run into the bridges chips, this, that, and the others happen. Framework comes back, it doesn't fit. You've got to section it, reseat it, and then send it off again. There's all sorts of issues that can come. Whereas with single teeth, it's dead easy to do.
So it's dead easy. So that means without a surgical guide, or are you using a surgical guide?
I th- I I think it should be, yeah. I think people should be using surgical guides. That doesn't necessarily mean guided surgery based upon CBCT. As a minimum, it should be off a wax up with like some sort of pull down stent. The the only the only time I'm not that fussed with that is if I'm doing again like an upper premolar, which is an immediate, or where I've got teeth either side, and it's blatantly obvious where the implant needs to go. But if it's the last standing tooth of the arch, or I'm something a little bit not sure or anything along those lines, then yeah, I think it needs to be. You need to have a guide of some kind, and I think the more complex it gets, the more I start to switch towards guided surgery, and I think guided surgery is going to become more and more the norm in the future, because what's already happened, is if you place an implant and something goes wrong and you haven't got a CBCT, you're going to find it very difficult to justify why you didn't take one. Then if you have a CBCT but you didn't get a guide made, something goes wrong, and you get called up in front of whatever general dental counsel or whoever it is, they're going to turn around and say, you had the scan, you didn't make the guide, why? And it's going to become very difficult to justify.
So now in 2016, are you starting to do CBCTs and surgical guides more and more and more?
I do CBCT for most cases, but I'm definitely doing more and more guided surgery, even if it's just to do the pilot hole, because we've only just got the denser burrs in the UK for about the last 3 or 4 weeks or so. So
You only got the what?
The denser burrs. They when you put your motor in reverse, is instead of drilling the bone out, it compacts it laterally. So in the maxilla, it's really good because it densifies the bone as opposed to getting.
And that's called a densa burr?
Densa, DENSAH, yeah.
Oh, densa. Okay. DENNSH?
DENSAH.
Okay, there it is. Densa burrs.
Yeah.
I love it when I learn something new. See, I only do this podcast for me. Oh, nice. Nice. So talk about the Densiburs. It's made by Versailles.
Verso. I'm not sure. Not sure how to pronounce it, but they're fantastic burrs.
Huh. And how long you been using those?
Just a few weeks.
So it is brand new.
Well, it's new to the UK. I know it's been available in the States at least 18 months or so.
Right on.
And
Go ahead.
I was just going to say it's kind of like the old osteotome and mallet, but it's not the mechanical version of that. What happens is the flutes are designed in a certain way, so when you put your motor in reverse, that it burnishes the bone laterally instead of getting rid of it. So they call the concept osteodensification, and I've managed to get posterior maxillar. You can get fantastic stability, absolutely fantastic stability.
Very nice.
Yeah.
So when you do a surgical guide, how are you usually making your surgical guide?
I do one of two forms. So either I'll just get my lab to do a wax up, and I'll do a pull down from that, like a sectional Essex or something like that. Or if I'm using fully guided surgery, I'm using a system called SMOP. SMOP.
SMOP.
SMOP, yeah. And I think it's very similar to the one that Armand's running as well. It's kind of like a spaghetti.
Which is Cadbray?
Cadbray, yeah. I think it's similar, yeah.
So tell us about SMOP, SMOP. Where'd you find this one?
It was actually introduced to me by a friend of mine, and I went on the course, and it was very clever. It was
what's SMOP stand for?
The company who runs it is called Swiss Mader. So they're based in Switzerland. I don't know what SMOP actually stands for. Even they just call it SMOP. They just say, yeah, this is our SMOP guide. And what they do is they take the scan. You get a digitally scanned model, and you can overlay the two. And then the technicians they make a guide which is then 3D printed. And instead of it being like a closed system, which a lot of the old type guides were, it's got like, they call it like the spaghetti guide, because it's literally like bars which cross over, and it's fully open, so you can raise flaps and still see exactly where you are as well. And the guy who did this he's not a dentist, he's actually an engineer. And he was actually hired by the university to prove that you don't need guides. And the first thing he said when he looked at the old style guides is he said, well, you don't need those ones because they're not going to fit properly. So, and that's where this all came from. And it's not a universal panacea. You can't use it 100% of the time, and you still have to be able to do it manually as well. But what it will do is it will, in over 90% of cases, it will improve your efficiency and your overall positioning as well.
So, what about price on these things? Are you in London, or where are you actually at?
I work in a number of different practices, but one of my practices is in London. Yeah.
And do you think do you think price has a very elastic effect on demand? I mean, you look at the United States cars. I mean, you got a Cadillac, then less money. It's a Pontiac, then an Olds, and a Chevy. Do you think price is very elastic on demand? I mean, when you raise your price a little, does that kind of reduce demand? When you lower the price, do you get more demand? Is it very price sensitive in London or in the UK?
If we take London slightly separately, because London's a very saturated city, so what applies there doesn't apply to the rest of the UK. But the rest of the UK, to a certain extent, it's price sensitive. And what we find is if it's £2,000 or less, just under £2,000, is they fly like hotcakes. As soon as you go above £2,000, is the number of people going ahead reduces significantly. But that's not to say that you can't charge more than that. But
so do you keep your eye on cost a lot? I mean, do you try to make that a competitive advantage, or or is that not your overall?
Well,
What is your unique selling proposition?
I mean, I don't go out of my way to look at everybody in the area and go, okay, I'm deliberately going to go cheaper than everybody else in the area. There is more than enough business for everybody out there. You know, we don't have to. If we all helped each other instead of trying to hinder each other, we'd all be much more profitable. And I really vet my patients when they come in. If I don't think that I'm going to get on with them personally, I actually don't. I make up some sort of excuse and say, I don't think I'm the right person to help you, and let them find somebody else. But what I do is I try to be reasonable with my fees. So if somebody's coming in and they need multiple implants done, it's not going to take me that much longer to place 2 on this side, 1 on this side, as if I was just doing 1. So then I am more elastic with my prices. What tends to happen is my hourly rate stays about the same. So it's win-win for everybody. So I'm elastic, but not deliberately to try to underhandedly cut any corners or undercut anybody in the area. I'm elastic because I can be, depending on the patient and what they need to have done.
So about 82% of our listeners now are U.S. So 2,000 pounds would be $2,900 in the U.S. So yeah, $2,900. Now, is that just for the implant, or is that for the implant and crown?
That's for the implant and crown as well.
That's the whole kit and caboodle.
Yeah, and simple bone grafting as well is included in that fee.
So is your fee inclusive? When I talk to a lot of patients, my first question is, why did you leave the last office?
Yeah.
And you always hear financial problems, not with the price was too high. It's like, well, he said I needed a crown. Yeah. But then when I checked out, it was a crown and a buildup. He said he was going to do an implant. Yeah. But then when I got up front, he did a bone graft and he did some other thing, and it cost almost twice as much. And I think these dentists are kind of like accountants and engineers. They don't realize the people skill that you can't go to the grocery store and it says gallon of milk $3, and then by the time you get to the checkout line, it's $5.
Exactly.
So you're just shooting a one fee for the whole implant and crown.
Yep. I look the patients square in the eye. Once I've had the discussion and answered their questions with regards to the procedure and made sure that they want to have it done, I wait for them to ask me, Pav, how much is this going to cost? And without hesitation, I'll just turn around and say, for your clinical situation, it's £2,000, all finished. For your clinical situation, the number of implants you need, it's £4,000. I can do it for £1,500.
Okay, and then how do you warranty it? What happens if something goes wrong? What's your warranty?
Well, I turn around to the patient. I turn around and say, look, I'll warranty it for 12 months. They turn around and say, oh, you're only doing it for 12 months. I turn around and say that, look, if biologically for whatever reason your body's going to reject it, or if there's some sort of issue with the actual crown itself, I said, it's going to fail well before that 12-month period. It's not that you're going to get to 13 months, then like the fridge that you've got, is as soon as the warranty runs out, that's when it's going to fail. So if there's a genuine issue, it's going to fail probably in about 3 or 4 months. Beyond that 12-month period, it's kind of like, it's, I turn around and say to them, beyond that, it's down to your risk factors and how you manage it. Now, depending on the patient and, and how nice they've been to me, whether sent in any referrals, if they come back 15 months later and there's an issue, sometimes it's an easy fix. Just do it. Keep the patient happy, but I think the other thing as well is, because I'm hearing this a lot where my patients come in to see me and they turn around and say, oh, Pavel, the guy down the road or the lady in the next town, they turned around and said that implants have got a success rate of 95% over a 25-year period. I'm like, well, that's not how it works. So what I find is I'm open and honest with them. And sometimes I turn around and say to them, look, your treatment's complex. You're going to be lucky to get 10 years out of it. And they'll go, okay, let's do it. They just want to be told the truth. And as you said, they don't want any nasty surprises with the treatment or the fees. So if you quote them a certain fee, stick to it. If you've not treatment planned it properly and it's costing you more, that's down to your diagnostics. You should really take a hit in your own wallet to keep the patient happy.
So, Pav, I want to ask you a question, but I don't even know how to ask it, because I want to say, well, what do you think the success rate of an implant is? But in all seriousness, I don't think the profession of dentistry has decided on what the definition of a failure is, because
That's
what I
it.
see is if it's still in the mouth and the
Yeah.
tooth's on and you can
Yeah.
bite through a cracker, it's still functioning. I mean, you could lose half the bone. There could be, so what do you think the success rate is, and what do you define as failure?
I think failure is, again, it's dependent on the clinical situation and on the patient psychology. So I have seen some absolutely beautiful cases posted on Dental Town, which are so out there. It's they're like 98% of where it should be, and it's only like a 2% because there's gingival margin. It doesn't quite creep down at the correct angle. For some patients, that's a failure because it doesn't exactly match the tooth on the other side. For me, I'm more like yourself. It's like, okay, if it's further towards the back of your mouth, as long as it's healthy and it's functional, for me, that's successful. And the problem is the more strict we start to become, the more our failure rates start to go up. And there's this whole thing that keeps going around time and time again, where people turn around and say, you know what, if I see your implant, it's failing.
Yeah.
If it's my implant, it's surviving and it's fine. So there is this whole grey area, and I agree with you. It's really difficult to define. And when my patients ask me what the success rate of implants is, my answer to them is the success rate of implants is 100%. I said, but the success rate of your biology is not going to be that. I said, I know that implants work. The biggest question is your biology and how you look after it. If you're not prepared to look after it, I recommend you go on holiday instead, because it's not going to last.
So, what do you think of these? Well, let's talk peri-implantitis.
Yeah.
How do you avoid peri-implantitis? How do you
Yeah.
treat it? Because if you're doing a lot of single tooth implants, someone loses a tooth, they want to implant there, but you go around their mouth, they might have a 6 millimeter pocket on the other side. They might have,
Yeah.
they might have perio. Talk about peri-implantitis, because that seems to be the biggest buzzword on Dental Town.
Yeah.
If you were going to pull up all the implant threads and say what's the most asked question, it's peri-implantitis. So rant about that.
Be very, very strict with who you do implants on. Just because somebody's had perio in the past doesn't mean that they can't have implants. But I want for them to demonstrate to me that they are committed to looking after everything. And on top of that as well is look at your soft tissue thickness. If your soft tissue isn't thick enough, graft it. Learn to do pedicle grafts. Learn to do rotated grafts. Learn to do roll flaps when you're uncovering implants. That is if it's a larger area, use alloderm out of a packet. Use Hydrosorb. Use whatever you need to increase the thickness of the soft tissue. And then what I do is I turn around and say to my patients that if I think that they're at very high risk, I'll actually turn around and say to them, I want you to see the hygienist every single month. Will you commit to that? And sometimes I turn around and say, no. I say, well, there's no point in me doing your implant for you. I said, I'm going to be wasting your time. And I'm very strict with my follow-up as well. So when I fit and screw everything down, it's all cemented, I'll show the patients how to clean around it. And here's another big issue that I find is when dentists, I don't know what products you have in the US, Howie, but in the UK we've got little interdental brushes. They're called TPs, and I find that dentists and hygienists, they're prescribed the wrong size. It's far too small, and they're getting them to go in between the teeth, but not actually below the gum line. And if people are being taught to floss and clean around implants, is they just go up and down as if you was it. The implant's a lot narrower than what your tooth is. So I show the patients, I get them to hold the mirror and I do it. I said, look, when this brush goes between your teeth, look how big that brush is. Can you see how it goes? I send TPs off to my lab and I say to them, when you're constructing it, make sure that can go through so that I know that it's cleansable. So it's a whole range of different things that we need to look at.
So, and the next probably most common asked questions is to screw or cement. Are you a screwer or a cementer?
Both. Both. I haven't got a problem with cementing. I think the biggest problem that people have with cementation is they don't do it properly. And what they do is they treat it like a crown. So they get the crown, They shove it full of cement and they shove it onto the abutment and they wait for it to set. Then they're trying to clean everything off underneath. Now, I listened to your podcast with Carl a month or two ago, and I've started using zinc phosphate cement as well. And what I will do is I will get a replica made of the abutment, not on the working model. And sometimes you can do it off the crown. Is you just put a little bit of whatever you want onto the inside, and even stick the end of like a micro brush into it, so that you've just got something that the crown will sit onto. Then what I do is I load the cement into the crown, shove it onto that duplicate model, and you'll see all the excess cement come out. I clean it off, then I take it off and put it onto the abutment, and there is no cement below the gum line. So I think a big problem that people are having is they're trying to cement implant crowns as if they were normal crowns, and that's what the big problem is.
Yeah, and then what do you think about, let's say you do have peri-implantitis, how are you treating that, and what do you think of these guys on Dental Town that are sticking lasers in treating peri-implantitis with lasers?
Certain types of lasers can help. Again, it's got to go down to basics. So you've got to get the patients cleaning again properly. I think the perio flow done by the hygienist regularly, that's been shown to help as well. If obviously, depending on the complexity of what's going on, is you can get things like R brush from Neobiotech, and this is it's like a little titanium cage. It's got little prongs.
It's a what by who?
It's by Neobiotech. I think it's called the R brush or I brush. So what you do is you take the crown and the abutment off the actual implant. So you've raised your flap, and you've got the your exposed titanium, which is all infected. And so when that titanium is infected, the eye brush sits on top of it like that, and it rotates at high speed because it goes into your surgical handpiece, so it rotates it, and it effectively polishes the surface of the actual implant itself, and that's been shown to be pretty good. And I also think that, okay, once you've done that, once you've got the patient cleaning better, check your soft tissues. Are your soft tissues thick enough? It's Giovanni Zucchelli, he's doing some really crazy stuff over in Italy now, where he's taking patients who've got peri-implant mucositis, exposed threads, and he's treating the peri-implant mucositis first, grafting underneath, but you still got exposed threads, and the inflammation goes away. And it's really interesting.
I want to switch to fear and scarcity versus hope, growth, and abundancy. I notice so many people think in fear, and what I notice is that no matter what community you go into, there's some dentists who see all the other dentists as competitors, and then the other half see them all as their buddies. And I remember when I got to Phoenix, half the dentists across the street were all upset that there was another dentist, and it was all fear and negative. And the other half were like, "My God, let's go have a beer and watch football." And the ones that thought in hope, growth, and abundancy just had so much more fun. And I've always so I'm introducing the question of mentors. I think so many kids come out of school and they think, well, that dentist over there is not going to show me how to do that because he doesn't want me to know how to do that. And talk about mentors. You've had mentors. You mentor others. What would you say to these young kids about finding a mentor and learning from them? And because a lot of times they feel like, well, it's got to be a professional relationship. I have to fly across the country, give you $5,000, and listen to your course. When there's a periodontist or an oral surgeon or a general dentist or an implantologist literally up the street from him that they could walk or ride their bike, that would gladly show them everything they would learn in a course, but they just they don't want to. So talk about that. Talk about
the two different personality types that you just discussed. So the positive attitude, those are like, let's be friendly. They're the best mentors to have. And quite often what you'll find is particularly those who own a practice, particularly if the practice isn't doing so well, they feel very protective of it, or they feel that if they teach you something, that you're going to start stealing all of their patients and stuff like that. They don't see the bigger picture. Whereas if you speak to the people who are actually really happy to mentor, is they do it A, for the love of the profession and teaching, B, because they want to help patients indirectly. So they think if I teach this person indirectly from me, they're going to help somebody else as well. And it's just asking around and finding the right people. You know, there are some people out there who, you know, who are brilliant mentors, and the opposite end of the opposite end's true as well. There's some people out there who are charging ridiculous fees to be mentors, and they're very protective, and they're not really teaching. What they're kind of like doing is they're kind of like going, oh, you know, this is what I can do. I will show you the super simplistic stuff so that you have to refer everything else to me. And that comes across very quickly as well. And it's one of those things how it is, there's no way to figure it out 100%, but, you know, just keep asking, keep engaging with people, and it will become apparent over time by itself, the people who are happy to teach you and those who aren't.
Yeah, helping another dentist is the ultimate leverage. I mean, there's 7 billion earthlings and 2 million dentists. So there's only a dentist for every 3,500 people. So every time you help one dentist, you just help 3,500 people.
Exactly.
You know, it is massive leverage. But yeah, I think the mentorship thing is amazing. We just kicked off a mentorship program this year on Dental Town.
Yeah.
And it took off a lot faster than I thought it would, because there's just, and by the way, everybody's a mentor. Like when I was in the first grade, I was a mentor to my little sister Kayleen in kindergarten. But I was a mentee to my 2 older sisters who were in the 2nd and 3rd grade. You know, I mean, you're just, that's the way you are all the way through life. I mean, you're always going to find someone who has sunk more implants than you, and you're always going to find someone who's placed less, you know, your entire life. So are you liking this program?
Sorry?
Are you liking this program you're in?
Which one? The MClinDent?
Yeah.
Yeah, I'm really enjoying it.
You're back in the homework mood, and you're studying for tests and all that stuff.
Well, I never really got out of that, to be honest with you. I've always when I had to study, I didn't enjoy doing it. Now that I don't have to do it, I enjoy doing it. So it just comes naturally to me. I was relatively confident going in beforehand because I'd already done a course and I'd read Carl's book and a lot of other books as well, and I thought to myself, this will be interesting to see how much I'm going to get from it. But you know, I'm learning a lot, and I'm absolutely thoroughly enjoying it, and it's structured as well.
In that Carl Misch podcast, what shocked you the most about that podcast, or what surprised you or changed your mind? You mentioned that zinc phosphate cement, you know, that. That is there anything else that kind of grabbed you? Because one thing that grabbed me is the fact that he will place implants on smokers, and his brother Craig won't. And I see that in the valley here. I mean, there are oral surgeons and periodontists that, and it's not just for implants. It's breast augmentation. It's facelifts. I mean, they just say you cannot even have a cigarette for 90 days to make an appointment. If you've had one cigarette in the last 90 days, get out of here.
To be honest, I was more shocked that his brother insists on 0 smoking if he used to place implants. My general rule of thumb is 10 or less per day is manageable. Now, I know some people don't agree with me, but again, it's taking that in correlation with the other risk factors as well. So it's, you know, how old is the patient? Do they have any other co-pathologies? How complex is the treatment? And do they have perio on top of it already? There's one guy today, because of his medical history and his smoking as well, I said to him today, if you don't cut down to 0, I'm not doing your implants. So for him, his specific case, he was you cut your smoking or I'm not going to help you at all. He was one of those cases. So I think, and one of the things that really came out in the assignment that I've done recently as well is the use of antidepressants massively. It impacts healing as much as what uncontrolled diabetes does. So say that again. The use of antidepressants as prescribed or abused? No, prescribed antidepressants has the same effect on bone metabolism and reduced healing capacity as uncontrolled diabetes.
And which antidepressants are these? Are these your serotonin reuptake
All of them.
inhibitors?
All of them.
Prozac?
All of them. Every single one.
So over here, I assume it's over there too, with Prince dying of of an overdose of fentanyl.
Yeah.
So back when I got out of school, the United States had 30,000 car wrecks a year, 30,000 accidents, 30,000 suicides. And then out of nowhere, we got a new 30,000, but it shot all the way to 47,000, and that's opioid overdose.
Yeah.
Oxycontin, Vicodin, Percodan, fentanyl, all this thing like that.
Yeah.
So the question is, or what pain med are you prescribing after these implant surgeries? And as all this opioid addiction, does that change your thinking, or
We can't actually prescribe opioids in the UK.
you
It's
can't?
it's very difficult for us to prescribe opioids in the UK.
So you're talking about Vicodin,
Very
Percocet?
strict. No, it's. I mean, I'm not sure about those names, but basically, what we prescribe is basically paracetamol and ibuprofen.
What was it? Ibuprofen and what? Acetaminophen?
Yes, yeah, acetaminophen.
What did you call
all I
it?
give. A paracetamol, it's called. That's the generic name in the UK.
Paracetamol?
Yeah,
Oh, so the UK is really makes it hard to prescribe opioids.
yeah, yeah, yeah.
Huh.
For me, it's 12 milligrams dexamethasone just before the appointment, and then it's paracetamol, the acetaminophen, and ibuprofen. That's it. That's
And
all I
are you
prescribe.
having much complaining about that afterwards?
Yeah, I have some complaining, but thing is if you explain something's going to happen to a patient beforehand, it's a warning. If you tell them afterwards, it's an excuse. So what I do is I turn around and say to my patients, it's really going to hurt, it's going to be really painful, but you'll be fine, not a problem, particularly with the bigger cases, and they accept that. And what happens is the pain isn't as bad as what I've made it out is going to be, and they come back the next week and they go, oh, well, it wasn't that bad, and so I say, well, fantastic, that's not a problem then. But it's I think it's very difficult, and I'm very wary of any patient who comes in and turns around and says, I want no bruising and swelling afterwards. I turn around and say, we're doing an invasive surgical procedure. If you expect no bruising and swelling, I said, you need to find a magician, not a dentist. So it's I think a lot of it's in the communication beforehand.
This is an argument I always have with my dental assistant for 30 years. She gets very mad if I set anything on the patient's bib, which is on their neck area. And she's like, you can't set something on their neck. I was like, look, if I was doing a bypass, they'd be naked.
Yeah.
Okay, so I'm doing a root canal. I'm a doctor. I get to set something on your chest. If you want it to be, if I can't touch you and you want me to do a surgery or an implant or a root canal, I don't understand how the surgeons are fine with taking all your clothes off, but I can't even set something on your neck. And so what other I want to ask you. There's a very famous implantologist in your country who's creates a lot of controversy on Dental Town because he's always placing very short, fat implants.
Yeah.
And a lot of the old time schoolers think, the implant's got to be really, really long, go out the back of your head and wrap around the moon 3 times and come back. What do you think about the move towards these shorter, fatter implants?
Firstly, I think Bill is a brilliant surgeon, and what he documents as well is. And
you're calling him out by name. You're calling out Bill Shaver. Are you guys in the same neighborhood?
No, he's right on the south coast.
He's on the south coast?
Yeah, I'm about 250, 300 miles away from him.
And what about Jason Smithson?
Yeah, he's very far away as well, probably about the same distance as well.
Yeah.
Because I messaged Bill about this, and I said to him, have you always been comfortable placing short, wide implants? And he said, no. He said that when I first started placing them, he said, I was actually very apprehensive. He said, but then I didn't have any major issues. And he became more and more confident with it. And if you look at the studies, I'm pretty sure this is in Carl's book as well, it's only the coronal 5-6 millimeters of bone or so that actually transmits any force. So the biggest overriding factor by a long shot, and this has been demonstrated in studies, is the width of the implant. you want as wide a body as possible while still respecting the bony border. And I'm happy placing, I think the shortest implant I've placed is 6 mm. Doesn't phase me in the slightest.
Now, is it the same Megagen, or are you using a fatter implant when you're going 6 mm?
I use a much wider implant when I'm going like 6.5 mm.
But still Megagen?
Yeah, it's Megagen, yeah.
Okay.
Yeah. But
Well, I always think it's good news when anything shorter and fatter is better. I want to be the poster child for the short fat implant. But hey,
in fact, I was on a course recently, and it was run by a Max Fact consultant, and he actually said on the course, he said that if you're placing anything more than 10 mm implants, he said you're doing it for ego. He said you don't need anything more than 10 mm nowadays. That's how much implants have come on. That's how good implants are.
Well, Pav, seriously, dude, you're my idol. You're old enough to be one of my kids. I'm old enough to be your father, but I'm telling you, your 4,000 posts on Dentaltown have been since 2000. I can't believe you've been posting for a decade. We're getting old, dude. Yeah. I've been watching your stuff for a decade. I'm not sure when I'm going to be out there. The date's on howardforan.com, but it's I leave not this Thursday, next Thursday.
Okay.
And I'm in London, and then the week later, I'm in Glasgow.
Yeah.
And then in between, in the middle, I'm in Paris. But maybe if we're lucky, we could hook up. When I went there first time, my son Gregory, who I'm taking back again, he's now 20. What is he? 25. And I think the first time I took him to London, he was 10. So here I'd always want to do a father-son trip, and I'd take my boy all the way to London. And the only thing the only thing he would talk about when he came back, everybody's like, well, how was London? Was fish and chips. He just, oh my God, everybody they'd say, I'm pretty sure all he did is went there and ate fish and chips. He doesn't mention anything else about London. So it's going to be fun going back with Greg, and we absolutely want to find that fish. It is a very unique experience, fish and chips in London.
It is, absolutely, yeah. It's like going to New York. You can't go to New York and not have hot dogs. No, you can't come to UK and not have fish. I
got to tell you my funny UK story though. So the first time we got there, I was speaking to the what is it called, the Royal College of Dentists, Royal College of Dentists.
There's a Royal College of Surgeons, yeah.
Oh, it's a Royal College of Surgeons.
Yeah.
And we walked out our hotel and we saw this big Ferris wheel.
Yeah.
And which is the London Eye, and we didn't know anything about it. And I said, Greggy, we got the whole day. Let's just walk over to the Ferris wheel. We'll see the city.
Yeah.
We left the hotel probably 8 o'clock in the morning. We got to that Ferris wheel at about 9 o'clock at night. I mean, it was so deceptive on how far away it was. Of course, we cabbed back, but it was the most exciting all day, a 12-hour walk. Every block in London was a bookstore, a restaurant, a bar, this. And the other thing I'll never forget is on every single corner waiting to cross the street, everybody around you was speaking a different language.
Yeah.
I mean, it's
very, very cosmopolitan.
Oh, yeah. The sun never set on the British Empire, and you can meet people and go to restaurants from every single country on earth in London.
Yeah.
But, I hope I see you next week, buddy. But, again, thank you for all that you do for dentistry, all that you do for Dentaltown, all that you do for your patients. I just think you're just one of the coolest guys on earth. I really appreciate it.
Dentaltown's such a fantastic resource. I've learned so much and been put in contact with so many people that I now call friends. And, I've got your DVDs and stuff, and it's just a fantastic resource. And like you said, nobody should have to practice alone, and nobody does anymore. Not if they have Dentaltown, at least, anyway. So.
All right, Pat. Well, thanks again, buddy.
Thanks, Howard.
Bye-bye.